Hello to everybody. My name is Farah Mahferat, a medical doctor, gynecologist. You're already used to some short videos. Actually, I started new topics about the OBGYN. Today I'm gonna to explain a little bit about the bleeding during the pregnancy. So we'll be very brief. I try to summarize all issue, and of course perhaps I will forget something because I'm saying because of the social media, time limited and other issue, so we don't have too much time to speak about all the tests. Let's go to the main topic. So bleeding during the pregnancy is sometimes is a really major concern, but in general I can say most of bleeding is not a real problem, most of them. So why most of them? Because to my experience, more than 70 till 90% of the bleeding, nothing happened to pregnancy. This is, I'm saying, it's not from the literature or from the book or only internet. This is due to practice which is going for many years. And during the let's say couple of years, I saw many patients with bleeding, and almost most of them we solve it and not big concern. But there is some like a tiny issue which make a problem for the patient, could make a problem for the patient and especially for the baby. So we have the like a first trimester, second trimester, and third trimester. During the pregnancy trimester, when we talk, is like a 13 weeks till then 25, 26 weeks. Then the end is 26 till almost 40 weeks. So it's not like a 9 calendar month, which is the 36 weeks, but it's 40 weeks during the pregnancy. You know it very well. So anyhow, the first trimester bleeding, vaginal bleeding during the pregnancy could be different reasons. The basic one is due to vessel rupture in different area of the uterus. It can happen retroamniotic. So this is the first. The second one could be a retrodecidual or retroplacental. That means between placenta and the uterine wall, which is the myometrium. So this can happen. The other issue could be some cervical damage or erosion, which we have like a small tear during the pregnancy. Can happen by microtrauma, by vaginal extra discharge, autoimmunity, infection, and or microtrauma during the intercourse, which can cause. So they are the basic reason of the bleeding. And for us, that the first trimester is very important, is two main thing, which is, I don't talk about too much about the other pathologies like a fibroid, a polyp, and of course this concern we have to check everything, but we talk about the most reason of the bleeding. So two things is very important. One is the ectopic pregnancy during the first trimester, especially early time of the pregnancy, and the second is the abortion. Is like a misabortion or a spontaneous abortion can happen. So this is important. Ectopic pregnancy diagnosis is not really complicated. So let's say max 6 weeks can be diagnosed very well. Max, I'm saying max here. So could be earlier. Max can be diagnosed. Sometimes we do the SCG, but not really necessary, because SCG double growth help, but is not like a ultrasonography. When we do ultrasonography and we see there is no like a fetal pulse or fetal structure in the uterine cavity, and is 6 weeks of the pregnancy, test is positive from the urine or finally gravity test. So high suspicion of the ectopic pregnancy by ultrasound almost easy can be diagnosed. So this is a very important. And another thing which I said important is the abortion. So it can happen like a abortion we talk could be like a threatened abortion. That means it's a bleeding, like a spotting, rather than like a too much bleeding. It's a spotting, but the heart rate of the baby is functioning. Could be like a inevitable abortion, which is really under progression. The like a prognosis is bad, so progressing for the abortion, which is not good, unfortunately. And then we have the like incomplete abortion. Some part of the tissue still remain, and some part is expelled from the uterine cavity, and complete abortion. So very quickly about the bleeding during the other reason which I said is a vessel or micro vessel rupture. So bed rest, hormonal support, especially with the progesterone groups medication, and vitamin C, ascorbic acid like ascorbic, and vitamin K, which we can give. And of course, if it's necessary, we send patient to the hospital. Sex abstinence and rest, and will be followed. And if something is wrong really, so then go to a hospital and will be more under observation, and plus laboratory examination. And about the abortion, which I said quickly, so the abortion, if it's like a miss abortion, unfortunately, complete abortion, okay, we check the sonography and we see the uterine cavity is clear, nothing is left. So at least due to ultrasound, the examination result is good. If something is left, we can still wait, not hurry, because if the patient doesn't have fever, if not heavy bleeding, if not pain, or infection, so we can wait. And maybe sometimes by medications such as oxytocin helping to the other tissue, if remaining, come out from the uterine cavity. If not, then patient can be sent to the hospital for revision of the cavity, uterine cavity, especially by vacuum aspiration and evacuation. And of course, if it's necessary, we do the RCUI, that means like a curettage, but very gently we clean out the uterine cavity, and patient will be hopefully discharged fast, quickly, the second day maximum, and will be waiting for the next pregnancy effort, and the doctor let you know. And of course, I have to say here, what I'm saying is like an educative process. It doesn't mean you should absolutely have the competent what I'm saying, or what you should take it like 100%. This is my experience, my practice and experience. I didn't examine you, I didn't see the file, I didn't do the ultrasound for the patient now, like who listening to me, so I cannot say exactly what is going with the patient now, because I'm in other country, you're in other countries. But please, if any problem, what I'm saying, you ask, you consult with your doctor, your dear doctor, he or she try to help you according to the actual condition of your medical situation, or about the pregnancy. What else we can talk is about the second and third trimester bleeding, which we put in together, because after 13 weeks now placenta is prominent, is already developed, and is growing. That means from the thickness, from the length, and will be bigger and bigger, and supporting hormonal nutrition and oxygenation of the fetus plus metabolism. So all the mechanism by circulation and done. So in this case, it's so important. Right away we talk about the placenta. It could be a low location of the placenta. That means it's near to the cervix, rather than upward to the anterior part or posterior part of the uterus, or the fondi of the uterine cavity. So if it's a low location, the doctor shouldn't make lots of stress for patient. They know it very well, but I'm just saying it's education. I'm talking to you. Just keep like a peace of mind, and wait, follow the patient if the patient doesn't have a problem. So then slowly, if it's really proven of the placenta previa and it's covering the partially like a cervical os, or the interior cervical opening or os, or the complete covering the placenta previa as a fully cover the cervical cervix inside the uterine cavity. So then really we can warn the patient of the placenta previa, not right at the beginning but wait, and is so important, especially for the physical stress, for the intercourse activity, sport activity, and so on. So this is important. Usually patient will be followed up by ultrasonography. No need for the lots of tests, no helping at all if it doesn't have too much bleeding. If it's like a slightly, so that means the hematocrit and hemoglobin almost remain the same, they're slightly changing, so you can give the iron therapy and helping. So we go to placenta abruption, which is very important, is risky, and placenta abruption is a very rare situation, but it can happen usually due to etiology like infection, chorioamnionitis, due to multiple pregnancy, like twins, could happen. Multipara, that means the patient or the lady already delivered a couple of or many babies, at least 3 for example, after cesarean section, so this can happen. And or simply the ovum or fertilized eggs nidation, or like a implantation was very low, so this can happen. So this sometimes causes the placenta abruption, and placenta abruption could be total or completely or partially. Usually if it's happened is partially, and if it's happened fully is so drastic situation, the doctor or hospital has to react very well. And very easy, I mean easy, not easy, the management should be fast, and deliver the baby quickly, cesarean section, and take care of the baby, the pediatric, and then pregnant lady with the OBGYN. And also when we are talking about here, could be the second and especially third trimester, heavy bleeding during like a before delivering or during the delivery. We have to be careful about the DIC, that means disseminated intravascular coagulation, which is combined of the like a bleeding, heavy bleeding, abnormal coagulation factor, almost most of them, and also thrombosis, which is could be thrombosis, and finally can cause the pulmonary embolism. It can hurt the heavy bleeding, and clot can hurt the distant organs such as kidney, and also can make a problem with the anterior hypophysis. There is a gland which producing many hormone from our brain, the anterior hypophysis or epiphysis. This could cause also, it's called Sheehan syndrome. Sheehan syndrome, which is like somehow there is a necrosis of the glands, the epiphysis, and the epiphysis cannot produce the amount of the hormone which ladies they produce, such as, let's say, give example, prolactin, and it can cause also patient during the after like a delivery, patient without milk, so because cannot be produced because there does a lack of the prolactin and other hormones such as oxytocin. Yeah, so this is so important. The management, as I said, should be quickly, like blood tests, coagulation tests, kidney tests, liver tests, and whole to intravenous fluid, especially plasma and erythrocyte, like a blood if it's necessary, we have to give, and of course anticoagulation and antithrombosis we give during the delivery if it happens. So very, very like a prompt reaction to the situation. And right away when we are here, during the, right away after delivery, we did the delivery. We check the cervix, we check the vagina. We encounter the hypotonus of the uterine muscle. That means the uterus activity is decreasing and doesn't have activity, the contractions. So the whole area which the placenta was implanted starting bleeding, and it's like a thousand macro vessel bleeding, could be heavy. So we have to react, we have to stop with the medication. Finally, manual massage of the uterus. We have to check the cervix rupture, we repair it. Cervix rupture is not really complicated, can be repaired quickly, fast and easy because there is a mass, there is a tissue. But then vagina is important because the vaginal epithemes they are very fragile, especially during the delivery, during the pregnancy. Will be so like very mild, and can rupture, can break down. And breakdown is a small, no problem, but if rupture is huge, so sometimes can go the rupture to the end of the vagina, like a vaginal cuff, and has to be repaired and reconstructed, the vaginal epithelium. So that's the way. So I hope this video helped you. Any question, any comment, you can write, and if I have time, for sure I will answer you. I forgot to introduce my name. Sorry. My name is perhaps you know already, but just Farah McBride, a medical doctor, OBGYN, and a GP, general physician. Thank you very much for your attention, and hope to hear from you with more communication from both sides. Thank you. And I try to prepare. Prepare. I always in my brain, I'm talking about everything when the patient most likely asking. Thank you, and have a nice day. Bye.